So welcome back. I'm Christine Sinsky. We're going to start the next panel, and the panel is titled, Freeing Physicians to Care for Patients. Now, can you imagine that title? When I was a physician in my early career and looked at what the computer might do, I never thought that we'd be sitting here 20 years later talking about freeing the physicians for better care. So it's no secret that EHRs have profoundly changed the nature of care, much of it for the better, but in ways we didn't anticipate, somewhat for the worse. And I will count myself among those people who didn't anticipate some of the hardships that we would encounter. I can vividly remember being in the emergency room, admitting a patient in the middle of the night, and handwriting the patient's 20 medications from one place to the other. And I know that I made transcription errors in the process. And I was dreaming of the day when, with a click of a button, all that information would transport. What I didn't realize was how many clicks that would be. And it's time. I didn't realize that tasks, and we've done these time studies in our practice, tasks that took me 2 to 3 seconds to do in the paper world now take 2 to 3 minutes per task. And you multiply that by the hundreds of tasks per day, and you start to understand some of the time compression that physicians are feeling with this new and powerful technology. So where are we now? Well, as we've heard already this morning, we know that our physicians spend 2 hours on EHR and desk work for every 1 hour of direct face-to-face time. We also know from work down the road here at Sutter, at the Palo Alto Medical Foundation, that physicians who have 100 inbox messages a week have twice the rate of burnout. And yet, family physicians and general internists have 400 inbox messages a week. They have almost 100 a day. So that is a Sisyphean journey that many of our physicians are on and haven't been able to get away from. We also know that the more EHR functions that are turned on, the more the rate of burnout goes up, and physicians' intent to leave their practice also goes up. But these are fixable problems, and we have a panel here today that's going to help us talk about those fixable problems. And we're going to be thinking about fixing these over a 3 to 5 year time frame. And I've asked our panelists to be focusing on solutions and to be focusing on concrete, tangible solutions that we can envision now or that we can be doing at this point. So help me welcome our panel up onto the stage. And Sam, I'm going to start with you. You're my neighbor in Wisconsin. Mm-hmm. We've been on the stage several times together in the past. And I've heard you say that you have an MD degree, a medical doctor of data entry.
Yeah, I said that one way we could solve this problem, when I go around and I talk to physicians and they say, I didn't go to medical school to do data entry. And I say one solution to all this is we could just change the label on the medical schools, School of Medicine and Data Entry, and then we wouldn't have to do this problem. I am Sam Butler. I'm a physician. I have been at Epic for many years, and I am the Chief Medical Officer at Epic today. And yes, I think that right now we have a problem. I look at lots of data in a new evolving field. We call it signal at Epic, but it's the data that's pouring in about how physicians use the EMR and what we're spending our time on. And I'm looking for patterns of information. And what I'm just struck with mostly is how much time everybody is spending writing notes. Notes are 3 and 4 times what they spend on orders and chart review and in-basket, the 4 major areas.
So what do you see in the near-term horizon, very concrete, that you and your colleagues can do that will help to change that, so that instead of spending 2 hours on EHR and desk work for every 1 hour with patients, we're getting that note done more concisely, more quickly?
Yeah, I'm going to focus on notes first, and to answer your question. I think it's going to be a multi-pronged approach for the technology at Epic and other EMRs. We have made it easy to make our notes very long by both copy and pasting and being able to put links into the notes that make it really long. And what we need to get away from, we need to as physicians, we need to take back the note and make it a tool that is serving the purpose of communicating to our future selves and to our colleagues, and not all the other reasons. Now, those other reasons, quality and billing, They're important, but we can do that without having to put it in the note. And we're still in a very notes-focused world where so often I hear compliance officers say, well, if it's not in the note, they didn't do it. And I can't look at any other report in the EHR because, well, I just don't. I always look at the note, and that's where it needs to be. We got to get away from that. So in the next 3 to 5 years, we should be focusing on changing the culture and education of how we write our notes and what's expected from a note, and not the large super note that we've heard about.
Great, great. So I'm going to build off that and turn to you, Andy. You are the Chief Medical Officer for ONC, Chief Clinical Officer for ONC. You sit in the office where meaningful use was crafted and where a lot of pain for physicians may be located, or at least where we as physicians might locate some of that, the responsibility for that pain. What Sam has envisioned requires multiple stakeholders to play a role, right? We need technology vendors to make the tools built so that we can have concise notes, but we also need regulators to help us change the regulatory environment so that we can write shorter notes. If it wasn't in the note, it wasn't done. We need to get away from that. What's one thing you dream of coming out of your office in the next 2 to 3 years that might help to reduce some of the administrative burden?
Thanks, Chris. First of all, I'm probably the only Fed that's going to be on this platform all day long, as opposed to the former Feds. So as a Fed, I have to do that disclosure thing. My comments may or may not necessarily reflect those views of the US government. We're also in a regulatory process, which means I really can't speak to some of the work that we are actively doing as we finalize our rule.
Sure.
But we have published in our proposed rule some really exciting things, and I'm going to just sort of very, very quickly touch on them.
Perfect.
The first is we have, at Congress's request, said that what are the exceptions to information blocking? So those, OIG, which is the Office of the Inspector General, now has new authority to make sure that information flows. And we were asked to say, when is it okay for that information not to flow? So we published that information. We also, as you heard Raj speak on the last panel, we have also been, and for those of you who know me, I've been in the safety space for a long time, and was the mover and shaker behind that thing that Erica showed, that report that came out of my office. We have very strongly supported the notion that when there are errors in the EHR, and that clinicians ought to be able to communicate what those errors are. In fact, we feel so strongly about it, we did a contest last year, awarded some grants to make it easier to actually report those things. So I was trying to figure out what color button was still left. Blue was taken. I'm from Dartmouth, so I think green, but green didn't have the negativity. Red was just way too negative. So some form of yellow. But again, that hasn't quite yet been implemented. And you think about it, one of the young medical officers that worked for me came to me one day and said, Andy, I don't understand. The video games I'm using track what I've been doing for the past 10 or 15 moves. Why can't the EHRs do that? And when there's a problem, I just say, hey, there's a problem. And a voice box opens up, and I say, this is who I am, this is what the problem was, and be done.
Right. So you're proposing, or have proposed real-time safety error reporting. I'm a clinician. I say, oh, I had a near miss there. I almost made a mistake. Let me highlight that for the people behind the scenes.
Yeah, and we're still seeing sort of great work being done. Folks at Columbia, the order and retract information, calling the clinician immediately when the prescriber does something and changes it, and to understand what was behind that. How many instances of patient charts should be open at one time on the AMDIS listserv? That's an ongoing debate back and forth. Usability versus safety, a little bit of a fight. So I left my anesthesiology and critical care medicine practice a while back. But the reason I left it was I see the same future that others in this room see for the technology and the transition from the paper-based record. By the way, can I just make one little small comment?
Oh.
Pajama time. So I'm the son of an obstetrician gynecologist. I used to wait up to have dinner with my dad, and it would be 6 o'clock, 7 o'clock, 8 o'clock, 9 o'clock. And at 9 o'clock, I usually was too tired and hungry. I'd eat the cold leftovers and go to bed. So my dad didn't have pajama time, but I didn't have the benefit of seeing my dad when he came home. And then I'll keep my mouth shut.
But that's a really good question, because your dad, during your pajama time, was off using his unique skills. Marc, we're going to turn to you. CMIO of Cerner, you mentioned that one of your hopes for the future, you're shaking your head, you know where I'm going, is that you can call home one time when you're traveling and talk to your internist wife or your physician wife, and she won't be in pajama time. She won't be doing her notes. She won't be doing documentation and inbox work, that she will be doing something restorative during that time. As CMIO of Cerner, what's in the near-term future that can reduce that pajama time, that can bring physicians back to their families, that can give us time to be part of the community instead of doing that Sisyphusian inbox work?
No, and it's very fair. And now I have my oldest daughter is now using Cerner, and when I call home, she's so so it's an ongoing challenge. But no, I think part of the answer, I think, for this near-term challenge, and Raj earlier highlighted some of this data, is clearly we moved quickly to implement EHRs across the country, and there was a lot of learning that went on. And there's been a lot of evolution of the systems over the last decade. However, one of the things that I think when we think about what could you do today is those best practices are not uniformly adopted. The 7 clicks versus 28 or whatever it was, I'm sure I have the numbers wrong, that Raj talked about earlier, for example, tells you there's a way to do it in 7 clicks. But for whatever reason, implementation or whatever, and again, to make it personal, I'm really fortunate that the practice that my wife's in has gone through in the last year a process to go back to what Cerner calls its standard implementation. And the time that physicians are spending outside of office hours has fallen dramatically across the specialties where they've finished that work. Often it's hours a day have melted away. It's still not good. It's still not where you want it to be. But by taking what we know, our best practices today and the learnings from the last decade, I think we can make a big difference. Now, that's not easy. That takes time and money from the health system. It's change for the providers. There's probably going to be things that the provider used to do that now we're not going to let them do or we're going to make them do. But at the end of the day, I think that we can make a big impact today just by adopting best practices uniformly across the country and continuing to learn from the data that's generated from that.
And I'm going to insert here a personal note. So I have used Cerner 15 years in the inpatient setting and 10 years in the outpatient setting. And I think the instance of Cerner makes a difference, right? But I will tell you that I think it's also not just the design and implementation and regulation of EHRs, but it's the social technological framework around that. So in my particular practice, I knew I had an inbox. I think I could find my way there, but I never, ever go there, ever. How is that possible when it is such a weight around most physicians' necks? Well, as a primary care physician, I didn't go there, not because I didn't have in-basket work. I didn't go there because I have a team. And my team is the first responder to the inbox. And they're very quick to do the research behind every message and then come to me, and we go through many of those messages at one time. And that way I can spend the majority of my time on work for which I'm uniquely trained and am not having to do some of the administrative and clerical work that's involved in managing that inbox. So some of our solutions will be technological, but some of them are going to be cultural and team-based. So just wanted to add that to what you'd said. So Ash, you're now the Senior VP for Global Healthcare at Salesforce. Congratulations. I had to learn what Salesforce was.
Yes.
Now I know. But prior to that, you were in charge of digital implementation and digital strategy, I believe, at the VA. I'm wondering what part of your experience at the VA are you bringing with you to Salesforce? What anecdotes, what personal drivers have you brought with you from your VA experience?
So first thing, instead of talking about me being a federal government employee, so I had to give out the same sort of disclaimers that Andy gave out, now I give out forward-looking statements. So similar-looking things. So I brought that with me. But I think, you know, at the VA, it's interesting to come in with anecdotes of your own as a clinician or a patient or a caregiver, but when you're in charge of sort of leading a team to think about broader modernization of the digital and healthcare infrastructure, you work with a large group of people outside of just physicians, and you realize that it takes an entire ecosystem, not just to deliver care, but to come in with and deal with all the technology that comes into the workplace, right? So to your comment about inboxes, when I first started practicing medicine, we didn't have EHRs, or we didn't use them. So I was writing on paper charts, and I had a team, and I had people coming to me and working with me. But when we moved to the EHR, a lot of those functions fell on me.
Yes.
And so I don't know how we missed that. And so I think when I went to the VA, of course the VA was late in coming to the game on EHR modernization, but with it came lessons learned for over a decade from other institutions. So we had the visibility into learning from all of these challenges that other folks have faced. We chose Cerner as a system of choice to come in across the way. So one of the things we implemented there is bringing in the entire ecosystem into developing the workflows and understanding how we're going to map out our system at the VA, right? So that included not just doctors or nurses, but schedulers, other folks that are involved in the care, like the caregiver, care managers, et cetera. So now that I'm on the technology side, a lot of times tech companies are innovating at such a fast pace, and they're bringing in a lot of the new development that's happening in other parts of the industries, and they're just going so fast that they forget who the end user is, right? Bringing people like me into the mix is a constant reminder where I can say, stop, this is not how things work, right? So when you're developing technology, you say, when somebody goes into the emergency room and they leave, they don't automatically get assigned a care coordinator. So when you develop these flows in the system and you try to add it, that's not how it happens, right? Or at Salesforce, we build a layer that can sit on top of an EHR or ERP systems or other systems where we can bring in disparate sources of data into a single place so that we can tie all of that together and add next best action. But when we do that, for example, with the care managers, what I don't want to see is workflows that say, okay, this patient was discharged. The care manager mentions a doctor. I'm like, whoa, wait a minute. That's not what happens. And we don't want that to happen because you're adding to the physician burnout and the burden. So I think those are the things that we're bringing in and my team brings in to sit with them and co-develop.
And I think you're right that when EHRs were implemented, it was well intended or overseen. But the end result was many tasks that were done by others became the physician's responsibility. Things that were done by the medical records clerk, by the transcriptionist, by the pharmacist, suddenly became the responsibility of the physician. And a colleague of mine was the first to bring it to my attention that our colleagues in the legal profession are not asked as lawyers and judges to simultaneously do their legal work and create the legal record of that work. But we have asked that of our healthcare professionals, and perhaps we've asked that in a way that's very costly. We just haven't measured that cost. Before I get to Edwin, I have something specific for you, but I want to open it up to the whole of the group. How can we be more thoughtful about task distribution? Because we've suddenly put this technology in that assumes, of course, the doctor should be the one who does X, Y, or Z. And now we've suddenly realized that the doctor can't do all of that, and they are leaving the profession because of that. So I want to follow through on your comment. And Ed, I'm going to give you the first opportunity to respond because I haven't otherwise given you that opportunity. And you are the CMIO at Kaiser, correct?
I'm actually the Chief Information Officer for the Permanente Federation, which is the medical group that partners with Kaiser Permanente.
Yes, thank you so much. For the Kaiser interactions are so complicated.
It's very complicated.
But the Chief Information Officer, as the Chief Information Officer for the Permanente group, can you key off this conversation about how can we be more thoughtful about where we distribute the work?
Yeah, no, it's a really, really good point. We've got a collection of team members that are looking at the body of work that we need to be doing to take care of our patients. So that could be the medical assistant, the nurse, the pharmacist, the receptionist, of course, the physician. Putting all those team members together is really the way that I think we can be able to take care of the volume of patients that we have in trying to do that in the context of working with the electronic medical record. We have to be very intentional about it. We have to recognize the fact that not everything has to be done by a physician. And when we do that, we look at the team members and we look at the technology. And we see where the gaps are and where the opportunities are to not only offload the physician from doing the non-physician work, which, by the way, I think is really at the top of why physicians feel that administrative burden. They're doing things that aren't physician work. And so finding those pockets of tasks that can be done by a nurse or a medical assistant and finding and building the technologies that can be done that don't have to be done by the physician, working together, talking, building systems really would enable the physician to, as a primary care physician, what's the right number of a panel size? Is it 2,000? Is it 1,000? Is it 3,000? It might be 3,000 if I can have all those things in place, but it might be only 1,000 if I have to do it all myself. And so I think about what was mentioned earlier about pajama time. And I'm just going to mention a quick anecdote here. About 10 years ago, I created a program. I wrote a program myself. I don't recommend that all physicians go out and start writing programs. But what it was an automation program that mimicked human interaction by clicking through the click path of what I would have wanted to do. Instead of clicking 10 clicks, I would click once.
Right.
It was kind of a selfish endeavor because I wanted to improve my practice. It was also selfish because I was looking around my colleagues and seeing that they were having these issues too. One of those colleagues was my wife. I was seeing her spend pajama time with her computer and not me.
Yes.
And so I said, what can we do to improve this? And now it's still used 10 years later by over tens of thousands of users, not only just physicians, other staff within our medical group, and feels like it's an indispensable part of our practice now. So
Sam and Marc, if someone can get this click pathway going, what can you all do? Because certainly I know that when I closed a note, I had to click, 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 and it was always the same to do that. I thought, why wasn't that all wrapped up into a single click? Help me understand.
So we do have that quick
And
action.
I didn't use your record, so
Right.
you're off the hook.
Right. So we do have quick actions where you can put a macro together for in-basket actions that you do over and over and over again. I think you can do all that. I see the adoption of quick actions to be very small. And I think it goes to another point. We recently had the opportunity, we were at a large academic medical meeting of a specialty, and we opened up a thing, we called it the Epic Bar, but it was like a Genius, I shouldn't say that here in Palo Alto, Genius Bar idea. And people came up and they brought their laptops and said, this is what I'm having trouble with. And we recorded what they had problems with. And 90% of the things were that they had trouble with. I used to say, well, it's likely that the organization hadn't done it yet. That didn't turn out to be true. 90% of the things were that they just, that were there, that were turned on, that we don't know about training, that we at least know that the feature was turned on and was present. They just didn't know about it. So when I go around and I say, are you guys using quick actions? I'll say to a doc, and they'll go, huh? How do we get people to take the time? I hear so often, I don't have time to learn to get faster. That to me is a big cultural problem. We have to, and it also goes to I was gonna make another point about the problem of heaping on to physicians largely, I think, is driven by physicians aren't as involved in implementations and optimization as they should be. They turn it over to other people, to the IT department, to design their workflow instead of being present at those meetings where it's decided they're gonna ask 7 questions for every chest x-ray or x-ray of the wrist. Somebody's gotta say, no, it's in the record. We're not gonna ask these questions. We're not gonna answer these questions.
Andy, I know you've got something to say, and then we'll go to you, Marc.
Yeah, no, and I think the point's well taken here, although I will go back and say, but on the other hand, the feature's there, it's turned on, but you got to click the invisible icon. I'm not.
Yeah, you got to find it, right?
I'm not dissing any of the interfaces here, but it's not easy to find. Sure. It's not easy to remember. It's like Word. How many of you write Word macros when you're, nobody, right? Yeah. Because well, a few of us are geeky. Yeah, exactly. But these are big, complex beasts.
Yes.
And we ask clinicians to do a big, complex job. And can we get better about the usability? Yeah. Absolutely. But there's also an element, I think, here of how do you streamline this, to your point of how do you streamline it within the context of regulatory and legal and privacy and all the concerns. And I think part of the answer, Chris, to your question is because somebody thinks that click needs to happen is why it ends up being that way. And some of that is usability testing. We might sit down with a group of 20 physicians and ask the question, do you want this? Oh yeah, we want that. You never want that to automatically happen. But sometimes it's in isolation. It's not in that broader workflow. And then you get the lawyers and the regulatory and the privacy guys going, oh no, we don't want to have that happening. So I think part of it is, like you say, it's that next layer of engagement of clinicians and UX designers and the operational teams to help begin to streamline these things. And Kaiser and Permanente I always kind of look at and with great envy because at least it feels like, I'm sure it doesn't to you, Ed, that you have much more flexibility than in many of our client settings, or Chris, where you're working in a shared instance of an EHR with 40 other practices, and the decisions have to be made in a compromised way sometimes, lead to these awkward situations.
Great. Andy, I know you wanted to chime in.
I did want to chime in, and that's not because I'm a Chime member. There is a history here that I think we have lost, and this is not going to be critical of my colleagues at the end, but in the early work of EHR development, EHRs were developed in a number of places, and many of those places were able to report, including our place, great satisfaction from the physician and nurses who were using those systems. What happened between that window and the substantial investment by the federal government to digitize is very interesting, because in those same entities, frequently it is more difficult now than it did. And part of that is because of all of the other masters. Right. Part of that is because you don't view health IT in the same way you view electricity and heating and cooling for institutions. Many folks, especially if the IT group reported up through the CFO, We're looking for an ROI. And you know, our ROI, at least one of our ROIs, was we got rid of dictation.
Right.
So the narrative went away. And absent the narrative, you can't understand what I was thinking when I saw that patient.
Right.
So there are a whole bunch of different things. And what I'm struck by, and Ed, you can correct me if I'm wrong, is that even in Kaiser Permanente, which is not a fee-for-service kind of entity, your notes are still pretty long. And they're still pretty long because in comparison to other countries, because we still have a medical legal climate where if it's not in the record, it didn't happen. So the change has to be really fundamental, deep, and not just ONC and CMS reg changes.
So I'm going to push all of us on this question because really a big part of why the EHR has been a source of burden, I believe, is because of the multiple stakeholders' interests that are being served via the EHR. So what can each of you do in your role, and what can you imagine one other entity doing in their role? So you can point the finger at the other guy, what they can do, but also what can you do? So I'm going to start with you, Andy, because you just were really on fire on this. What can you do,
so to speak,
or what could a regulator do to help to get away from this multiple master, if it wasn't documented, it wasn't done, compliance and legal concerns trumping clinical care, and actually creating a hazardous environment for clinical care because of clinical care getting pushed to the margin. So what can you do, you being regulator, and what can one other entity do? And I'm going to go down the line.
So first of all, what we can do, I'm going to speak for ONC, is what we're currently doing. And what we're currently doing is opening up the record, giving patients access that they already have through the Office of Civil Rights and HIPAA, but making it easier for that access to be actually implemented with open APIs, without special effort, FHIR, some version of FHIR.
Sure.
And so that's one thing we are actually doing. I would go a step further. As you know, we partner very closely with our colleagues at CMS around what are the billing and quality reporting requirements. I loved what Sam said because he said it, I didn't have to say it. You know, I would say it a little bit differently. Like all those other derivative actions
yes.
should not require the clinician
right.
to do something.
Right.
It should be a byproduct of their action in the record. One thing, as an anesthesiologist, I'm a consumer of other people's documentation. Our current EHR is full of duplicative, repetitive, frustrating documentation, including our famous CCDA. So what I'm going to ask my colleagues, you can guess which ones I'm asking.
You're looking down the line.
Not in a regulatory space, but I would love to see a tool where all of the brought forward, cut and paste, all of that was done in italics. Yeah. And the new stuff wasn't, and then a search function to be able to take me to the new content.
Yep. So, and I will just interject, before we had our current record in my practice, the older record, everything that was customized that you actually said was in blue, everything you imported was in light gray. So all you read was the blue, right? And you just scanned over the rest. So
absolutely.
Good point. Okay, Ash. Something you can do and something you would like someone else to do to help to address this regulatory, to the overall burden, administrative burden that's administered through the EHR.
Yeah, so we're not an EHR company and we are a B2B company, right? So we don't directly store or hold on to medical record data. We work with various vendors and with payers and providers to get these systems optimized. So in that role, like I said, we sit on top to ensure that the entire ecosystem is involved when we bring in all of the information. So we work really closely with provider systems to empower others in the ecosystem to work at the top of their license, and we build those into those workflows if we can get that on board. So as I said earlier, I think having PharmDs and nurses and nurse practitioners and others in the ecosystem empowering them and allowing them access to do the things that the clinicians would normally do, giving them access to the information so that they can coordinate some of that care, so that they have access to some of the inbox stuff that's coming in, will alleviate physician burden, and that's something that we've been sort of pushing forward and doing. Just in terms of asking others what to do, this may not be directly related to the EHR, but I think I heard you say earlier, physicians spend more than 50% of their time looking at the EHR, right? So we all know that's like $1 billion a day that's spent on physician cost. That's more money that's spent on, I think, any one single chronic disease allocation per day, or the combined amount of what we spend on our primary and secondary institution education. So it is a significant burden on the system as a whole. The reason that happens and the reason they're like documenting so much is because there are different standards for what needs to go into the EHR so that they get paid, right? So systems and physicians can get paid by the payer systems, and EMR vendors are required, happy to, I'm not sure, will work with the hospitals and providers to comply with these things. But I think we're at a time where we need to look at like the cost of this to the system, the cost to the clinicians, and we need to engage in a broader discussion. And I see some of the CMS work that's coming out, and that's great, but we need to get regulators involved to say, what is the national standard we're gonna set for payers? How do we have this conversation on private payers adopting these standards and EMR vendors changing their system so that we can reduce this burden, right? And we can start talking about how this will sort of reduce the burden of putting stuff into the system. I was at the VA, and I think we heard even at Kaiser, people write long notes. Well, at the VA, there's significantly shorter notes because we're salaried employees, and VA has, as you know, a budget that we get, so we don't have the same sort of constraints. And the notes are significantly shorter than when I work elsewhere, and I think that's a pretty good indicator that we have to change.
And we're on the verge of a natural experiment, right, coming up. If the 2021 E&M coding guidelines go into place, what will that do to pajama time? What will that do to note length and to note creation time? So I'm looking forward to that. Ed.
So I think what we need to do is, within my organization, is to continue to do value-based care, prevention, and quality care. We often talk about doing the right thing for the patient, and then things sort of falling into place with that, after that. We talked about the length of the notes within Kaiser Permanente, and actually we saw that chart earlier, and I've seen that, and we've plotted the Kaiser Permanente notes on there with each of our 8 different regions. And we're on the left-hand side as well, probably with where the VA is. We're not down to the international level because, well, we're still practicing within the United States, and we still are faced with some of those external pressures, but we're not as much influenced by the reimbursement. We're looking at the value-based care. And so that's part of it, I think. And the other part I think about is making sure that we're involving our physicians, the people that are actually using the system, to provide feedback. And we go out, it sounds very simple, but we talk to our physicians, see what their problems are, see what's slowing them down, talking about the metaphor that we use, what's the pebble in your shoe that's causing you the issues. And one by one, addressing those, it's time consuming, it's labor intensive, but those are the things that are affecting our physicians, and listening to them, taking them seriously, and acting on what they're telling us, I think is a really important thing to do. Now, externally, blue sky, and maybe it's not totally blue sky because at the last Epic user group meeting, there was a presentation about just sitting down, having a conversation, having the system hear that conversation with the patient through the natural course of that interaction, having that note put together so that I don't have to write the note, having the orders placed so that I don't have to put the orders, and having it all packaged together to eliminate the time that we need to do that as physicians. And when you talk about documentation time, that could potentially be practically eliminated, other than me going back and making sure proofreading, making sure it looks the way it should.
Great. I know, Marc, you'll relate to that.
I can't resist. You should have come to our user group meeting last week, and you could have used that tool.
It was a perfect setup, but it was absolutely
it was too good.
spontaneous.
It was too good to pass up. But no, I think for us, in this space in particular, Chris, and that specific question, that the best thing we can be doing, and we are doing, is helping measure these times and helping our clients or health systems who use our system and others know what the national and comparable values are. How much time is reasonable for an ambulatory pediatrician to spend writing a note? Is it 3 minutes? Is it 3.2 minutes? And that's not saying what is the best number, because we don't know what that is, because too short's obviously not good, too long is not. But starting to understand that and the impact on productivity that goes along with that in the context is, I think, the best thing we can be doing in this particular space today. How much time are the various team members contributing to the care of that patient? And we've even done some really, I think, fascinating work looking at, well, and what does that cost? We often think about the cost of care of the patient, and we say, well, there's no, for a particular episode, bundles, think about, so, there's OR time, and there's the anesthesiologist, those really expensive guys' time, and supplies, and the hip prosthesis, but we don't often look at, well, what was the people time that went into the care of that, because it's hard to measure and so on. So I think that's one thing that EHR vendors can and are doing by and large. If I'm going to point the finger somewhere else, is, I think that health systems are probably, there's so many things that they're trying to do, and they're spread so thinly that they don't have the time to do this. But I think it's critically important that health systems take advantage of the tools that they have today. That it's fighting the battles that are not necessarily, maybe it's building, clever little IT things, but I think a lot of it is working through what are we going to decide is okay to do internally? Is it okay if a nurse does this? How about an LPN? How about an MA? And making those decisions, and then fighting the regulatory battles that are often involved, that no, an LPN can't do that in Indiana or Illinois, but they do in 19 other states. Let's figure that out, because I think that's part of getting this team-based care, is getting that variability out, knowing what's possible and what the value proposition is at the end of the day.
So Sam, before I give the mic over to you, I'll just piggyback on that. I got an email from an internist at a large academic medical center 2 days ago, and she said, here's the latest for us. Now our MAs can't do orthostatic blood pressures. There was another piece incorporated into that, which again put more work onto the physician. So one of the things we've done at the AMA is we've created a Debunking Regulatory Myths website. And we now have 4 myths that we have debunked, and we link to the CMS or the Joint Commission language that indicates that CPOE does not need to be done by a physician, that medical student documentation doesn't need to be repeated to count for billing and down the line. So I think that you're so right that some of these problems do start with federal regulation, but they are exacerbated by overinterpretation, hyperinterpretation. Mm-hmm. And how do we free ourselves? And here I think we need data, and we need to understand that conservative interpretation of regulation and only the doctor can do responses are hazardous. They are not safe. They are actually causing it to be more difficult to provide safe care. So Sam.
Well, yes, I was going to, my ask for you was to continue with helping us debunk myths. I used it just the other day with a physician and sent them to your website. We looked at the one about medical students together. Yeah. We and the CM and ONC, not so much, but CMS for sure. Once, especially if these guidelines go through for January 2021, the new guidelines.
Yes.
Based on the AMA, we're going to need we're going to get payers on board, the other major payers to adopt the CMS way of documentation, and then physicians can document based on the time spent with patients, and that's probably of all. If we're going to not do value, if we're going to do a fee for service, let's move to that as soon as we can.
So what can you do?
So what we're going to do is, it's back to the notes. We are committed to trying to reclaim the notes so that the note becomes my communication to my fellow colleagues. Why am I not starting steroids? Why did I start steroids? Not how much steroids I did. And we're going to commit that the encounter report, we call it the encounter report, whether it's a visit report or the whatever you want to call it, that has all the information that anybody would ever want or need. And we need to get that report made for everything so that nobody can use an excuse to say, oh, that report doesn't have what we need. We need to make sure it's perfect for every situation, as close to perfect as we can for every situation.
And so will that be like a companion note so that you don't have to redocument that, but that
That's
the
right.
system
And for me as a clinician, I would rarely look at that report, I envision.
Right.
My world will be focused mainly on what we would call the note, the why. But if indeed I wanted to find out, well, what dose did they start? What did they change? With one click, I go a little bit deeper and I see that information. And then if I'm an auditor and I want to know, well, how much actual time did he spend in the EMR? That's right on their front and center page because they don't need to know why I stopped the steroids. Right. So each view should be tailored to the person who's looking at it. I want to know why the clinical decisions were made. The auditor wants to know how long or what quality measures we accomplished. We don't have to have the note be the master for everybody, and that's what we've been talking about. So we'll continue to work on that. At Epic, we got a new. There are so many reasons why people write long notes, and we're trying to address them all. One that comes to mind is that the physicians say, I need to see it all in front of me while I make my decision. And I can understand that. We learned that way. We wrote it all down, looked at all the data, made our decision, but why don't we make that go away? Or make it collapse to a citation so that if you did want to see what they were looking at, you can, but it's not in the note. So that's what we are going to commit to work on. Now, after 5 years, artificial intelligence may help us in a lot of these areas to, like in the demonstration where it actually reads the conversation and makes a summary note. That would be really cool if we get to that. And it's supposed to be 3 to 5 years, so we can hope for that.
Great, great. Well, I'm going to open it up to the audience and invite people who might have a question for our panelists. And I see a hand, and I have someone with a mic going around.
So how much of this is generational? I know Kaiser's got a brand new medical school where you're sort of digital first in your curriculum. And what is it that's so much worse about this electronic interface than it was so much better in the old paper-based world?
Go ahead, Marc.
I can take a first crack at that. So first of all, in the paper-based world, and I think there's very few people that we hear that say, I want to go back to that. But is that you could do anything, anytime, anyway, right? There were no restrictions. And all of you who practice in some form have seen the ills of that. Incomplete documentation, so I don't know what they were thinking, So it's not like it was perfect, but I mean, part of it is just that the medium of writing something illegibly on a piece of paper is tough to beat from a usability standpoint, but it's got its downsides. But I don't think it's a generational thing. I think that young physicians are struggling just as much as I am with using these tools because they're hard in some ways. It is hard to structure data, for example. I mean, why do they send you a $5 bill when they ask you to fill out some little survey or send you a Starbucks card? Because it's really hard to pick, what's the right answer on here? It's not the one I was thinking in my head. It was an okay flight, but the options I get don't have on them. It's some clever phrase. And so I think there are fundamental challenges in doing more, and I think, Chris, you eloquently talk about this. We are asking clinicians to do more, much more, with these electronic systems than we did, and it's fundamental human nature. It's not generational. The picture that Raj put up before of the blackboard and whiteboard, or the whiteboard thing, it's not generational.
Right. Thank you. And I know Andy, you wanted to
So
respond.
I don't have a pithy comment like death by 1,000 clicks, but I do have something that I think is actually valid, at least historically, and I'm not speaking as a government regulator at the moment. I'm speaking as a former associate dean in CMIO at an academic system. So this is burden by 1,000 good intentions. And so in the paper-based world, I could document whatever I wanted to document. And it was rare that someone would come to me and say, you know, you didn't do this, you didn't do that, or you didn't do some other thing. In the electronic world, many organizations have struggled with the same things we struggled with in the paper world. Only now in the electronic world, there are ways to do forcing functions and to make it more difficult. Or if I don't want to do something, hide my preferred path through 5 different click zones. So I think there is something that is substantially different in the digital world than in the paper world, and it's the control that's exerted on me. And I think in many ways, that's why we're pushing, we, the doctors, are pushing back.
Yeah, great. I think we have another question.
Hi. Oh, it works. Great. Thanks for coming out this morning. That was awesome. So Dr. Zenooz, you mentioned working at the VA. So I used to be a VA biomedical engineer. I know what it's like. So disclaimer, whatever I have to say after that. I want to ask, how is it different to implement an EHR in a large healthcare network versus a smaller provider?
Well, I mean, the sheer size of the VA, and we should probably ask Marc this rather than me because he's actively doing this right now, I suppose. The sheer size of the VA, you know, when you think about the vastness of it, it's like almost 2,000 sites of care, about 178 some large systems, large meaning middle and large size systems, and you know, close to 1,000 outpatient sites, and then you've got skilled nursing facilities, et cetera, et cetera. So coordinating across a large system like that and thinking about things like burnout and best practices and new workflows, and add to that all of the new innovation that's coming in from inside the VA and outside of the VA. And, you know, I think it takes skilled, talented group of people to come together to make that happen. From within the VA, from companies that are outside that are coming in to implement, as well as folks that have done this in the past at other large systems that may be similar in size or smaller to the VA, right? You should always have an ongoing discussion on new best practices. I just want to make a comment. You know, we've talked a lot about the EHR, but having been within the VA, the sheer volume of innovation that happens within the VA and the asks to connect into an EHR are incredible. And now you've got all of these outside systems that, you know, want to come in, new apps, et cetera, that are coming in. That we have to consider that when we talk about physician burnout, where it's not just about the EHR. I mean, I think EHR, I think they're great. You've digitized the data, but we're moving on into a new era where we need to like kind of rethink the concept of an electronic record and what it does. And having all of this data from patient-generated data, wearable data, bringing in all of the little data where patients are hooked up to machines, that all of that coming in, the alerts that come with that. We need to be thinking about how do we coordinate these so that we're not inundated? I mean, someone like me, I think you see, I'm probably the only one up here with a phone. I've got an issue with phones, right? So as soon as I see an alert, I want to look. If you put that, all of that information coming in into somebody's inbox, and it's coming in through the EHR, it's coming in through the alert system, you've got your, you know, VA or whatever inbox, you're going to stress somebody out. So I think that is, we need to have that conversation about integrating all of these different systems together. How are we looking at standards for these things that are coming in? Who's responsible for all of this data that's coming in? And I think those are the conversations the VA was, when I was there, that we were having. We were definitely, you know, wanted to have an open API gateway and a framework for that. They have since released that in, it's called Lighthouse, where they have a developer portal and open API, and they're pushing for FHIR standards. I think Josh will talk more about that so that we can bring in all of this data and develop and improve for patient care. But the broader conversation is, you know, is the data that's coming good? Have we looked at these apps and tested them like we test in clinical trials for the drugs? Like, what is the broader conversation that we need to be having here?
Right, great point, because I don't think any physician wants every Fitbit data point coming to them raw. And Raj, I think we'll let you have the last question because we have time for one more.
Great, thank you. So this is Raj again from MedStar Health's Human Factors Center. So my question is a general question for the panel, and it's about health equality. And so the kind of background or reasoning goes, a lot of the discussion on the panel is around optimization, and that costs money. And generally, the healthcare institutions that can afford it can move down that pathway, but there's several healthcare facilities that cannot. So the unintended consequence of that is you have this bifurcation, and the ones that can afford it then end up having more burned out physicians, more errors, and that exacerbates the health inequality problem. So how do we solve that?
Challenging last question for us. Who'd like to take a stab at that?
Well, I can start. One thing I think, Raj, it's a great question. It's a tough one. That is part of the reason I think that many organizations are moving to pure cloud-based implementations that help with the cost of deployment and ability to update on a continuous basis. Not that that's a magic wand, but I think that's one of the things that helps. Now, there's yins and yangs to it because, as Chris alluded to early on, you may not like what, it may be coming faster than you want. It may have things that you don't necessarily prefer. But at the end of the day, I think that will help reduce that disparity by driving the cost down for everybody, not just the folks who maybe struggle to afford today's approaches.
One more person? Yes.
The federal government is trying to help, Raj. You may have seen that just promulgated this week was a change in the kickback requirements so that there isn't an obligation for individuals who receive health IT from bigger places to contribute 15% of the cost of that, and that safe harbor, as it's expanded, will at least enable some of the more extensive distribution. By the way, the slide we saw earlier with 86%, I mean, that's ONC data. What I hadn't realized until I got to ONC, it's unlikely that 86 will get any higher because one of the requirements is that you have digital radiology as part of your system. So there are lots of ambulatory office practices that we would consider digitized except by that narrow definition.
Yeah.
I think there's lots of more and more ROI saying that teamwork, we have examples of people who have done good studies where they add an MA to go to 2.5 MAs per primary care doctor and see a dramatic improvement in revenue and profitability. So there are examples. I think we just have to where this optimization will help even those customers that are less financially secure. And I think, as we already said, making a standard implementation more the norm and having people accept the fact that the people that have gone before them have already made mistakes and know how to do it better. We can continue to improve that.
Well, I think from the comments that 3 to 5 years from now, things I believe will be better, and that there is reason for optimism and that there's a bright future ahead. Please join me in thanking our panelists.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.